here. So let's move along to the next session on linkage and retention and care, and we have the moderators, Michael Silverberg and Kirsten Bibbins-Domingo. You'll set the stage and call up the panelists as you need.
Thank you, everyone. This is the first time I followed a theatrical presentation, and it actually helps with getting up in front of, getting on stage to talk in front of people. So I recommend it. First, let me introduce myself. My name is Mike Silverberg. I'm a research scientist and epidemiologist at Kaiser Permanente in Northern California. We have offices in Oakland at the Division of Research, and I'm here to help set the stage with my co-moderator, who will introduce herself. And the format is going to be exactly the same as the first abstract session. So we're going to have a few minutes. We're going to keep it. We're probably not going to use our entire 10 minutes of setting the stage, and then we'll invite each of the speakers up to give a short 5-minute presentation, and we'll hold questions as before to the end, and followed by hopefully a lively discussion following all the talks. So I just have just a couple slides to set the stage. Do I advance these or? Yes. Oh, here. Maybe someone can help me. Oh, there we go. Got it. Okay. Thank you. So this is a slide that many of you are probably very familiar with, just showing the different levels where we lose people in care. And there's an estimated 1.2 million people in the United States living with HIV/AIDS. Over 900,000 are actually diagnosed, so about 20% don't know they're HIV infected. So we lose people at that stage. Among those, about 70%, and I have the corresponding percentages. So only about 60% of those are actually linked and engaged in care. And then if you take that a step further, 480,000 of the 725 are retained in care, are linked with a clinic or a physician and come back to care. And we lose some more people who are actually get on therapy when they're supposed to be on therapy. And finally, 328,000 of the 1.2 million are suppressed, have their viral load suppressed. So only 28% of the total are at the viral suppressed, or have their virus suppressed. To get the focus of the session is linkage and retention into care. And to get to that stage, you need to get HIV tested. And this is just some data from Kaiser Permanente showing our testing rates, showing that, yes, it has increased over time, but but looking over all our members, less than half have ever got a test. So it's increased, but we have a long way to go. And then finally, these are showing some measures over time. These are, I want to acknowledge my colleague, Michael Horberg, who's done a lot of work in this area for quality metrics, including retention in care and some other measures, as you can see on the slide, showing very high, at least in Kaiser, retention in care in the 70 to 80% range of our members who are diagnosed are retained in care. Now, so the missing 20%, there's obviously room for disparities, and some of the talks, abstracts that you hear from now, talk to some very innovative ways to try to keep people in care or get people diagnosed quicker. And I look forward to hearing those. Thank you.
Hello, I'm Kirsten Bibbins-Domingo. I'm a general internist and an epidemiologist. I work at San Francisco General Hospital, and I'm the interim director of our Center for Vulnerable Populations. I was delighted to be part of this conference. I don't actually do any HIV work, but I'm interested in health disparities and chronic illness. And so the topic for this session is really terrific because I think it brings together fields that many of us are interested in who don't do HIV work, which is now that you have a chronic illness and you're trying to engage people in ongoing care, what are the challenges to doing that, particularly for communities and populations who it might be more difficult to reach in an ongoing way. So I was delighted to see the abstracts here today because this field about chronic care and retention in care is about thinking outside the box in terms of technologies, in terms of how we organize our clinic sessions, and so I'm looking forward to a really terrific discussion today. So I am going to introduce our the first abstract. This is Bryan Chin, an urban HIV telemedicine program for specialty HIV services for underserved populations in San Francisco.
So I'm a community health program representative for 360 UCSF. I work with Dr. Malcolm John, primarily on our telehealth, telemed program. So let me tell you a little bit about it. Telehealth in general is the delivery of healthcare using telecommunications technology, and it's more commonly used in a rural setting or internationally, but we are doing it in an urban setting. We launched in 2008, September, and since then we've seen 180 patients in both group and individual sessions with a lot of repeat visits from there. So why an urban telehealth program? We found that there has been a lot of public transportation limitations, like for instance getting from Bayview Hunters Point all the way over to Parnassus could take an hour and a half with, transferring different, different buses or lines. In that same amount of time, you could drive to Sacramento. So there's also, patient psychosocial challenges. There's mental health issues and also substance abuse issues, which could hinder people leaving their communities to go seek optimal care, especially services. So this program is actually a method of resource allocation where we can give like pharmacy and nutrition services to clinics around the city that otherwise wouldn't be able to have a person on staff to provide these services. At 360, we see 18% African American. Our population is 18% African American, 60% is private insurance, and 40% is Medi-Medi. And our urban telehealth program is actually part of the Men of Color program and the Black Health Center of Excellence, which is part of it's a collaboration we have with SF/AIDS Foundation. So we work on a hub and spoke model with 360 UCSF as the hub, and 3 community clinics as the spoke, one is Maxine Hall Health Center in Western Addition, Haight-Ashbury Free Clinic in the Mission, and also Haight-Ashbury, and also South of Market Health Center in South of Market. We also work with 2 community-based organizations, Black Coalition on AIDS, and also our newest partner is SF/AIDS Foundation, which will certainly help expand our reach in the community. So we collected data for the first year. We collected patient data, and during that time we had 35 referral consultations, 12 drop-in sessions, and 4 group education sessions, which had about 8 to 12 people per group. And so the demographics of that group, we found 87% were male, 34% had AIDS, and a third were unhealthy SF or had no insurance. So, and most notably, they had detectable viral loads. About 65% had detectable viral loads, so they could have benefited from our pharmacy service, which is one of our services we provided. Here's some more data from our individual health appointments for the last 3.5 years. 42% were African American, and 74% of the actual appointments were nutrition. And we conducted a post-consultation questionnaire just to see, satisfaction and just see what people thought about the service. 79% thought that the service answered their health questions adequately. There was a little bit more of a spread when it came to confidentiality, as you can see on the graph on the right. But overall, people were very satisfied with the quality of the service, and they would actually return. 90% of the patients would return to UCSF. Return to access this service rather than going all the way up to UCSF for the same services. So for that first preliminary year data, we found that 1/3 of the total users were uninsured, which is actually a population we could not otherwise see at 360. Most of the patients felt that telehealth consultations with the pharmacist and the nutritionist were helpful, and despite concerns about confidentiality, patients were overall satisfied with their experience. So some of the lessons learned with this program thus far have been, it's really important to have a coordinator or a champion at each site. I guess I'm the champion at 360, but it's important to designate somebody at every site who can help scheduling, help coordinate the scheduling, and just understand the ins and outs of the program. Another helpful thing to remember when having this sort of program is to schedule during specific HIV clinics when it increases appointment, people actually coming to their appointments, and also anticipating drop-ins on the clinic end so that to have our providers available for when they come in to drop in. And of course, as with any technological equipment, there's always technical issues, so that should always be anticipated as well. We're also working with SFDPH on getting a billing model for this program. And there's several other future directions that we're working on, goals like further linkage to care with pre-testing sites, and also reaching out to target communities such as the African American, young adult, African American, MSM, and reaching out to them to try to connect them to care already. So I'd like to acknowledge everybody involved with the program, and if you'd like to contact me for more, I'm also going to be back there by the poster. So thank you.
Thank you very much. So our next speaker is Matthew Siegel, Amenability of HIV-positive African American men to shared medical appointments for primary care.
Hello, everyone. So I am Matthew Siegel, and I am a visiting scholar at 360. I also work with Malcolm John. And our study looked at the amenability of HIV-positive African American men to shared medical appointments for their primary care. So we know from various presentations today that HIV-positive men of color constitute a disproportionate percentage of individuals living with HIV, and they also experience poor health outcomes after HIV diagnosis. And this is due to a variety of factors, including low adherence to ART. That'll help. Including low adherence to antiretroviral therapy, mistrust of the medical system, low follow-up with primary care, and provider bias. And so the real focus of our study was to identify and research a method of care delivery that would address some of the factors that contribute to and lead to the disparity that we see. So we focused on the shared medical appointment, or the SMA, which is a model of care delivery in which medical care is provided to 2 or more patients concurrently, followed by short private sessions of history taking and physical examination. And evidence suggests that SMAs may improve, and this is all evidence found with other chronic diseases, that SMAs may improve patient trust in the medical system, medical appointment attendance, satisfaction, biological outcomes, cost of care, and provider satisfaction. And so based on these improvements, we hope that the SMA model may work well in our HIV-positive African American population to improve patient understanding of their health through increased interactions with the provider, also to establish a support network amongst patients at the clinic to address issues with isolation that we often see with this patient population, and lastly, to develop a skill set to deal with issues that are common to this patient population. So before we could implement a pilot program to study the SMA's effectiveness within this patient population, we needed to determine whether or not our patients were amenable to the idea of an SMA for their primary care. Receiving care in the group setting could be kind of a radical change for some people, and couple that with the stigma associated with HIV, people are not often willing to talk about it in group settings. So our study sought to identify the percentage of HIV-positive African American patients at our clinic who are amenable to the idea and willing to participate. We also wanted to identify any socioeconomic or socioeconomic demographic factors that might contribute to willingness to participate, as well as any programmatic design factors like length of appointment, for example, that were potentially associated with willingness. So this is actually a, okay, well, so I'll tell you a bit about our demographics with the study. So we ended up interviewing about 40 patients. So it was a small but ongoing study. The median age of our patients was 51 years old. We were 95% male, 50% homosexual, 28% bisexual, and most of these patients, 58% of them, had been with our clinic for more than 3 years. So the results of our survey suggested that over 2/3 of our participants were amenable to an SMA, which is encouraging. We didn't identify any demographic or socioeconomic factors that were associated with willingness to participate, although we did see a positive trend between patient satisfaction and willingness to participate, patient satisfaction with the current care. We also identified some programmatic factors, such as length of appointment, familiarity with other patients, confidentiality, that presented themselves as being relevant to willingness to participate. So based on these results, we feel that the SMA may be a feasible clinical intervention at 360 and at other clinics in urban environments. Our next steps are to implement a pilot program, and we'll be doing this in conjunction with Mallory Johnson at the Center for AIDS Prevention Research to study its effectiveness. Thank you.
Terrific. Our next presenter is Kirsten Balano, is presenting implementation of a clinic-based Mediset program for vulnerable HIV-infected patients.
Thank you. Thank you. I'm very happy to be here as a clinical pharmacist, and I'm super excited to meet Kirsten Bibbins. For ages, I was at San Francisco General Hospital, and we get your mail all the time as the two Kirstens at San Francisco General. I like the way you say your name, too. So I am on faculty with the UCSF School of Pharmacy, but my clinical practice is a bit north of the data that has been described here. I am in Sonoma County and in Santa Rosa. And what I'm going to describe to you is a strategy that we've been using for a number of years to help engage and improve adherence amongst our vulnerable population. And then we took a peek at those folks over the last 6 months just to see what kinds of quality improvement measures we needed to implement to this strategy. So a quick overview of our clinic in Santa Rosa. We take care of 550 or so HIV-infected folks at Vista Family Health Center in Santa Rosa. As a clinic, Vista Family Health Center serves 25,000 underinsured patients in the Santa Rosa community and is part of a greater organization called the Santa Rosa Community Health Centers, which serves 40,000 patients in our area. I do want to make a note that for 20 years we've had a HIV specialty clinic in the Santa Rosa area, and for the bulk of that time we worked as a county-funded community specialty clinic, and just over the last 2 years we've transitioned into these federally qualified health centers, which has been some of our impetus to look at the quality of our HIV programs within these new settings. So the model of care that we have is multidisciplinary for our 550 patients. We do not have an on-site pharmacy in this clinic. I serve as an adherence support and clinical pharmacy support along with our multidisciplinary team. So what is our Mediset program? Well, what we were finding is that we would identify some high acuity patients that despite multiple interventions were having a very hard time accessing or adhering to their medications. Some of the things that contributed to their high acuity you can see here. Storage, unstable housing, storage of their medications, some of the disclosure issues we have talked about, where patients are happy to take their medicines as long as the names of their medicines are nowhere to be found. And these are some of the issues that led to our strategy, which is as follows. What we do is we send prescriptions to an off-site pharmacy and request that they deliver it to our clinic. We then schedule an appointment for our patients to pick up their Medisets from the pharmacists or the nurses in the clinic. How often they return to the clinic to pick up their medications is really patient-specific. We have some folks that have come every week for several years. What we really want to also do is use our wraparound services to engage these patients around their high acuity issues. It's fantastic that we're giving them their medicines, but we try to wrap around their mental health support, their social work support, some of their other medical support as we need to. And we can then rapidly engage our outreach worker and our medical case management team for any missed appointments. What we're hoping to achieve when patients participated in this program is that we can move them from a high acuity situation to less high acuity, where their lifestyle and housing is stabilized. Perhaps we can at least increase the interval for them coming to the clinic, maybe deliver their medicines to their home, and that they're medically stabilized as well. And we try to assess their progress towards these patient-specific goals at regular intervals. So to just share, from about November to March, we looked at the patients who were receiving these services at our clinic, and there were 25 patients. You can see we have an 11-year-old in our clinic. One of the wraparound services as she and her mother come is parenting support. But up to 63 years of age. I'd like to point out that the majority of folks have achieved undetectable viral load, but these are folks who have a very diverse antiretroviral therapy history, typically have had CD4 naders that are showing that they have advanced disease, and have a history of trying to take medicines or a variety of different regimens. They are typically on 3-drug regimens, but can have higher pill burdens. And we also looked a little bit to see that the majority of them are taking a number of other medicines, likely for their cardiovascular comorbidities, pain management services, and a substantial number of them have psychological comorbidities as well. We made a intake form that asks a little bit about why are we doing this for this particular group of patients. And you can see that one of the biggest reasons we engage patients in this program is to help provide them support and connection. And I think that's been an interesting theme from this program, is that that's something our patients really need. And this is one way we offer it. My favorite reason is that patients are hesitant to learn new skills. There's a number of folks about going to a pharmacy, getting refills of medicines on your own, and then taking those medicines. That requires new skills for some of our patients that are hesitant to learn those. This is some of what our goals are that you can see where we're really looking to extend people's time or to stabilize their lifestyle and routine. I will say that this is not the perfect answer. This is a picture of one of the patients who's been coming every week for a month, and there will be gaps. He will leave the clinic with his medicines, and there have been times where his viral load comes back infected, and he's like, or positive, and he's leaving with the medicines but still not taking them. And so it's not the answer. We need to maintain those wraparound services to address the adherence issues. So what have we learned? We learned that this wraparound service and team-based approach is important. We keep it very patient-centered. The collaboration between the delivering pharmacy is really valuable. The majority of these patients are achieving an undetectable viral load, and we have a very rapid response to missed appointments. Our challenges in areas for quality improvement have to do with standardizing our documentation, our enrollment process, our disenrollment process, and being able to communicate adjustments to medication regimens amongst our team, and really creating a standardized policy and procedure. And with that, I would like to thank our multidisciplinary team of providers. Thank you.
Thank you. Our final talk is by Laura Mazzola, addressing health disparities in HIV with point-of-care diagnostics for rapid detection of acute HIV.
So it's actually going to be Amy Wong, because Laura is not here today, but so I will hopefully do equally as good. So I'm from Wave 80 Biosciences, and we're here in San Francisco, and I'm going to talk to you about the EOScape HIV RNA test that we're developing to be a point-of-care test that will hopefully bring patients, provide patients a diagnosis sooner, and of course, get them on treatment sooner. Does someone, do I? Okay, there we go. So these are some statistics that I think with all the speakers, of course, have gone through. We know that for African Americans and Latinos in San Francisco, the incidence of HIV is much higher than for whites. And even nationally, of course, the percentage of HIV cases, significantly, a large percentage of them are from minority populations. And San Francisco is this lower line here where it isn't quite plateaued as much as some of the other cities have. So what does that mean? So the health disparity, so one issue that Wave 80 Biosciences has tried to look at is how does this health disparity is affected by, and how do delays in diagnosis also affect the health disparity? So we know that a significant portion of Hispanics and African Americans don't actually have a very readily accessible source of health care. And there's a lot of reasons for that. Language, poverty, immigration status, simply being unemployed, or just don't have insurance. And so by not having a routine source of care, you would imagine that they don't have a very readily accessible source of testing. And so the CDC estimates that roughly 25% of HIV-positive Americans don't actually know their status. And not knowing their status actually is assumed to increase the transmission risk. And then by the time usually Latinos or African Americans are finally diagnosed, they're categorized as late testers, and they actually receive an AIDS diagnosis within 12 months. So is there a way that we can catch more patients? Given that Many of these populations are medically underserved, and they access their care in non-traditional settings, so not at the physician's office, perhaps not in your routine physical examinations. So can we actually get them at places like urgent care centers, emergency departments, and STD clinics? So that brings us to, well, why do we care necessarily about getting them sooner? And so there's a phase in HIV infection called acute HIV, which you're probably aware of, that actually is thought to be a higher risk of HIV transmission during this period. So there have been studies that show that your risk of transmitting the virus during this very early phase, the first few weeks, is quite a bit higher, 10 to 23-fold. And models have shown that even up to 50% of new HIV transmissions can be due to these acute phase. And so you could ask, well, do these people actually show up at the clinic? Well, they actually do. So, and of course, this is a Kenyan study, and we'd be interested to know if there's data from San Francisco or Bay Area populations about the people who actually suffered the symptoms of acute HIV, which are things like fever, sweats, diarrhea, vomiting, actually do seek care. And so they might not necessarily seek care at your physician's office. And there's been several studies that show that some of the viral syndromes that are seen in these ambulatory cares are actually, about 1% of them could be HIV cases. So these patients who then go to these ambulatory care settings may request testing. They request testing, but the testing could be for the testing that's used could be serological based, so antibody, antigen-based tests. So if you look at, here we're plotting the RNA levels in a patient's blood. This is ART naive. This is their CD4 count, and this is their antibody level. In the first few weeks of infection, during this first period, they're actually likely to be antibody or antigen negative. So the rapid tests or the OraQuick tests or those types of tests that are used may not actually show a reactive case. So is there a way that we can measure the RNA in a person's blood? So right now, the way that's done, if you wanted to get your RNA tested, you would have to have a blood sample taken, those samples then sent off to, say, Quest Diagnostics or some large laboratory, or if your hospital might have a sophisticated laboratory which has very large machinery that costs hundreds of thousands of dollars, and depends, maybe some insurance reimburse, some clinics can afford or can't afford this test. So there isn't really a point of care test that allows a patient to be diagnosed immediately if they're in the acute phase. So you can imagine if the patient is sent off, told to give a sample, and told to come back maybe in a day, in a few days, or a week or so, whenever they're able to come back, and given that a lot of these populations might have to work, they can't come back, or there may be migrant populations, maybe they're transient populations, can't actually come back or receive their results in time. So what we're developing is a point of care test, which is about the size of a Kleenex box that hopefully can sit on a nurse's desk or in an emergency department or in an STD clinic that can provide your viral load on the same day, same time as your visit. So the way that it works is that a cartridge is placed into this black handheld module, and a finger stick sample of blood is added to the cartridge. And then the cartridge is placed into an analyzer which reads the result and provides the viral load. And so we're looking for partnerships to actually trial this in an ambulatory care setting to assess how that can actually impact diagnosis and early case detection for HIV in San Francisco. So, thank you.
Terrific.
Yeah, absolutely, absolutely. So we're going to hear a little bit more from Matthew Siegel about their the shared medical visits, and because we didn't exactly have all the slides and data.
We had a mix-up with our slide deck. We had the wrong slide deck, so we didn't have any data slides. So hopefully this will give you guys a better visual representation of our results. So as we said, our study was into, the shared medical appointment, and we expected it to improve clinic visit attendance, improve patient satisfaction with care, improve patient health literacy, and increase the interactions with doctors and other specialists, as well as to build a support network around health issues that can address isolation, and also to develop a skill set to address issues common to the patient group. So our question was, well, I guess I'll cover the demographics again first, but our median age, as I said, was 51, 50% homosexual, 28% bisexual, and 18% heterosexual. Median years HIV positive was 21, and 58% of our surveyed patients have been at our clinic for more than 3 years. So the question which we asked was, I would consider participating in an SMA at this clinic, and the answer, to that was that 67.5% of our patients agreed, 15% said neither, and 17.5% indicated that they disagreed. And these are some of the programmatic factors that were associated with willingness to participate. If you see down here, it said if the program were led by my doctor, 85.2% of those patients indicated that they would strongly agree. Other issues that were important were that other group members had the same health issues as that patient, that they knew they would be asked to talk about their health in front of others, and it was extremely important for them to know that they would still have private time with their doctor. And then confidentiality, again, was right there at the top. Sure. And as I said, again, there was a positive trend seen between willingness to participate in an SMA and amenability with patient satisfaction with their clinic. Okay. Thank you.
Great. So we have time now for discussion. I think we heard some great presentations, and I thank Kirsten for pointing out a theme of allowing patients to stay connected in these care systems. We heard about from Bryan about a telemedicine program that allows us to reach out more broadly to patients who either for geographical reasons or economic reasons may not make it into care, from the shared medical visits, ways that may be more effective and maybe more efficient to delivering care on an ongoing basis. Learned about the Medisets, and interestingly, my favorite thing is that they engage people in all these other services, but may not be as effective sometimes in the Mediset piece, which is an interesting complication. And then, of course, new technologies to figure out how we can make diagnoses much more quickly at the point of care. So I'm going to open it up.
I'll start. I have a question for Matthew for the shared visit. Can you talk to some details about what aspects of the shared visit? Is it alleviating the isolation or stigma, or what are the specifics about a shared visit that might help with outcomes, and specifically to an HIV population?
I think a large component of the effectiveness of an SMA, especially in this population, would be addressing issues of isolation. We seem to hear from a lot of our patients that they do feel isolated, and that kind of circumstantially, you hear that patients even have issues talking about their HIV-positive status with their families, and issues that they confront in dealing with being HIV-positive. So if they were to be introduced into a group of patients that are going through similar issues and confronting the same obstacles, then and be able to share those experiences, share their own experiences, and also learn from the experiences of other patients, that you can build sort of a network, a community of HIV-positive patients, and address those issues of isolation, and that could create kind of a cascading improvement in issues that arise from isolation.
Can I just add to that, if I could? Sorry. Basically in other disease states like diabetes and hypertension, they've used group visits on a larger scale and studied outcomes. There's improved clinical outcomes. Patients have higher satisfaction, feel their doctors know them better. And, we wanted to apply that to HIV, but obviously we were concerned about stigma. We actually, in data not shown here, did 2 focus groups with our patients around this topic, and those issues came up as being important ones that they felt could be addressed with the shared medical appointments. And I just want to point out Matthew's continued to collect data in non-African Americans as well as African Americans. He's got now almost 80 patients studied. We just wanted to show the initial 40, and it's across ethnicities, some of these concerns. So.
Let me just follow up with that. How important do you think the data were sort of equivocal? How important do you think, and how will you structure when you expand this program? How important is it that to have groups that everyone is the same race, ethnicity, or has the same background? That usually the data is sort of mixed. That sometimes it's better and sometimes it's worse. And I'm wondering your general approach to this.
It seems that within this population, at least, that people having the same background or the same race, ethnicity is not a hugely important factor, or at least one that's relevant to willingness to participate with shared medical appointments. So I don't know if that answers your question. Yes, and we are also putting together a pilot program with which the structure is kind of evolving, but participants in the pilot program will be confined to being just African American patients. We're right now including 5 patients in each visit. We'll have 4 groups of 5. Right now it's 2 groups with Dr. John and then 2 groups with another fellow at the clinic.
So my question is about what are the ranges of topics that would be discussed on a shared level, and then when would you transfer it to individual discussion for the doctor? And are wraparound services also part of that discussion?
Yeah, so the topics of discussion would anything under the sun would be fair game. At first, we think that that staff at the clinic and the doctors would probably determine topics, and it would be anything that is applicable to this group. Topics could cover like healthy living, coping with stress, or dealing with the side effects of medication. And we feel that topics would then evolve to be sort of patient-directed and patient-driven, so that they can choose what the topics would be and what's important to them. And then as far as the privacy or topics that would be for discussion privately with the doctor, that's up to the patient. They are welcome to share as much or as little as they want to in the group setting. And then any other questions that they have, after each group session, each patient will have 15 minutes alone with the doctor for the routine checkup. And within that 15 minutes, they should also be able to address any topics that they would rather not share with the general group. Malcolm would like to add.
Just for clarification, so it's 1 hour with the doctor. We're initially going to have an organized set of topics should the patients want to do that. And Matthew, you've actually developed that with us. the example is if you spend 5 minutes with 5 subjects doing adherence talk, same message, 25 minutes in the course of seeing these patients, if they're with you, you spend 5 minutes once, and you've saved, quote unquote, 20 minutes that you can then answer questions, delve deeply, or what we were planning to do is to bring in our pharmacists, nutritionists, psychiatrists. Psychiatry was a big question that came up in the focus groups, to kind of delve more deeply in sort of a medical support group. And then we break for one-on-one sessions, 10 to 15 minutes in the second half. And while they're waiting for their one-on-one time, they do an art therapy project with the Art for Recovery group here at UCSF.
Terrific, terrific.
So I actually have 2 questions for 2 different speakers. For Kirsten, was there any differentiation between the outcomes of virologic suppression for those who got wraparound services compared to those that may not have? And was there anything specific in terms of which of the wraparound services were more correlative? And then for Amy, what specific type of setting would the point-of-care diagnostics for doing an RNA be applicable as far as practice?
So I'll go first. So, this was really more of a quality study. You look at the program, just trying to get a sense of who are we serving and what are their baseline viral loads. We didn't have time to look more deeply at it. It has set up a policy and procedure and a way of collecting data that we will then be able to really look more specifically at those outcomes. A number of the detectable viral loads were also because people were early in their therapy and on their way down. So I think we really do need to look at those that still have detectable viral loads in this program so that we can understand ways to improve quality as well.
Excellent.
In terms of the setting for our eScape platform, I think we envision places like emergency rooms, or even if a physician chooses to do point-of-care testing at his office, especially at sort of these minute clinics or STD clinics. So we have been trying to work with Chris Pilcher and trying to design a trial at the Urgent Care Center at SF General so that we can actually assess whether or not that is the best place, or if there perhaps are ways that we can change the design of the device, or see where it might be more useful to use it in different settings. So, yeah.
Hi, thanks so much for your presentations. It was really interesting to hear some of the very innovative work that you all are doing in getting folks retained in care and getting the best care. And I was struck this morning by the discussion around how there are a number of folks who get tested but that never actually link to care. And I'm wondering what your thoughts are in terms of the lessons learned from your programs, or how your programs might be extended to actually get the populations that you're working with into care, as well as the retention that you're already doing.
Yeah. One of the projects we're working on is actually a linkage piece to connect with different pre-testing sites around the city, so that when people come back and to get the results, they can speak, if they would like to, they can speak directly with a provider from 360, to answer any kind of questions that they have. So that's similar to what we're kind of looking into at Black Coalition on AIDS. They're actually they're doing a program with the Kaiser Foundation to actually get young adults in there and tested, and then we would connect with them and and be at that point of contact when they may have the most questions, and we can offer our services that way.
Right. Oh, go ahead.
I mean, the one point that I would make is that this was one of our strategies to help link some folks that we were having a very difficult time linking into care. They knew that medicines were important, but had a number of challenges getting to their medicines, and there was an increased opportunity for them to engage and decrease their barriers to care when come and get your medicines was the reason to come into care. That made sense to them. Come and get therapy wasn't, that wasn't on their radar screen. But, oh, I'll get my medicines, and oh, by the way, gee, it's the same day we've got our therapist here. Isn't that fantastic? So it was one of our strategies to help create the momentum for people to be engaged in care. And some of the stories would be that, there's so much effort that goes into this that sometimes patients, I shared a story that wasn't as great of an outcome, but certainly we've had a variety of them that say, you guys care so much, maybe I should. And that's a very interesting progression through some of these resource-intensive strategies that it move from enabling people, like here's your medicines, to empowering them to take it on themselves. And it's transitioning people through that and lowering their barriers so that they can engage.
I also have a question for Kirsten. You showed a slide of the barriers, the lifestyle, excuse me, the lifestyle barriers to adherence. And I was wondering, how did you measure that? Did you actually have a measure, or was that?
No, so it was, I think we had identified some acuity measurements. So our medical case management has some acuity measurements, and those are included in their acuity measurements at intake. Those don't automatically transition people into this more intensive program, but those are some of the things that contributed to people being referred to getting their Medisets. And then we had the slide where it was our, so were you talking about the ones that helped us identify who might need this? Yeah, those came from some acuity measurements that our intake form does.
Okay, it's not a standardized measure, it's one that you
No.
develop.
Yeah, no, the standardization is an outcome from this, that we need to standardize this. I think somewhat the editorial point is that sometimes when you're working with people who have chaotic lifestyles and a lot of chaos in their life, and they come into clinic with all of that, we can get really wrapped up in that, and yet we're doing something that's we want to get them the right medicines at the right time and all of that. So we're trying to create some structure to this that will help us let people have their chaos, but we maintain our quality.
I have a question for Bryan. Can you describe a little bit about how the spokes for the hub and spoke model work for those that are not in clinical care settings? So how do people, when they come into those settings, how does that community organization do the follow-up that might need to take place on the ground there?
So for those community-based organizations like Black Coalition on AIDS and SF/AIDS Foundation, we do educational group sessions. So it's, we connect with their support groups that they may have, and we dial in, and then one of our providers is actually, running the session and answering questions that way, to a whole group of people. And, in that way we can actually connect and get a feel for who is maybe in need more of optimal care, who could use better care, so that in that way we can link them in, to get our services and maybe enroll them in the Men of Color program or the Black Health Center of Excellence. So,
This is a question for Kirsten. Yeah. It's a very resource-intensive program you're describing. I'm wondering if you can give us a sense of, I think it was 25 people in the program. How much staff time, what kind of people are involved in helping making it work?
So it is a very resource intensive, which is why we really wanted to look at this and make sure we were reaching the folks that most needed it, and it wasn't just a convenience issue. The primary folks that make it work is our pharmacists, and we now have student pharmacists in the clinic that are really valuable in helping to make it work. Our nurse case managers are also incredibly involved in this. And, really everyone on our multidisciplinary team, and we do keep our, we use our Ryan White funding as part of our way to be able to maintain some of this strategy. Is that your question?
So we're at our time limit. I don't know if we started a little bit late, but do we have a few more minutes for discussion? Are there other questions? Come to the mic.
Hi, I'm Donna Odierna, also clinical pharmacy, but I never get your email. I've been looking at multidimensional factors in retention of diverse and disadvantaged populations in research studies. So there are contextual issues, like you mentioned, transportation, and there are study issues like staff training or protocols, and then there are differences between the people who we are able to retain and those we are not. So you're working to retain very hard to retain populations in clinical care, and I'd be interested to know, what do you think the differences are between the people you're able to retain and those who get lost anyway, and what kind of programmatic and contextual changes would we need to be able to reach those folks? Not so much, well, what's it about them that makes them hard to retain, but what is it that we can do better to retain them?
So you're talking about not in clinical studies, but you're trying to identify the characteristics across these different experiences that might characterize patients that you want to, that make it difficult for to retain?
I've been looking at research, but it's very closely related to retaining people in care, because a lot of times the studies actually are provided. So I wanted to know your perspective on that, as providing care as opposed to mine as primarily research.
So maybe any of the the characteristics of patients that make it more challenging?
I mean, I think the disclosure issue is one of the big challenges where, you know, I mean, we talk about disclosure to other people, but I think there's a process where people have to disclose to themselves and really truly identify and then take care of their HIV. And when they are in between and not sure that they're really infected or that's really true, then it's very hard to engage, because they don't have that identity or that importance, and they'll have a list of other things that are far more important for them to take care of. So it's competing priorities and the sense of disclosure to themselves sometimes, as well as others that are close to them. That's the hardest. I think that's one of the hardest groups of folks to really engage. And if we can move them to, well, you are infected, let's start treatment, which is a big one, they can identify with that, and then we'll wrap some of the other pieces around.
Any other thoughts or characteristics?
Well, just thinking about, I've been working, there's a lot of patients that at Maxine Hall Health Center that we've been working with, and there's been a lot of times when it's hard to get follow-up patients, people to come back. And it's been a challenge, and I've been really trying to figure out how to get them to come back, because they seem to have very similar characteristics. Like, they don't have phone numbers, they don't have addresses, so it's very hard to reach them. So I think a matter of really collaborating then with those clinics, and if they do have a case manager or they do have a social worker who does see them more often, and then who can link them in to our services and make ourselves available on a drop-in basis. So, you know, we have clinic on Tuesdays and Thursdays when all of our providers are available, our pharmacists and our nutritionists. So having them available for a drop-in in case that, like, these certain patients come into that clinic, and having ourselves available, that's what I'm looking forward to. Actually, this week there's somebody coming in to there that I hope comes in, because it's actually through the social worker that has been set up, has a drop-in visit. So,
Any last questions? Thank you. Thanks to our panelists.